Good afternoon, and welcome to the first session of our Palliative Care webinar series, Communication Skills for Effective Advanced Care Planning with Your Patients. Today's webinar will be recorded and made available in RPA's e-learning portal, which you can access through the RPA website. During the webinar, we do encourage you to ask questions. You can do so by putting them in the Q&A box below. For today's presentation, you will see a link in the chat so that you can download the presentation to follow along. Today's webinar presenters will be Dr. Alvin, affectionately known as Woody Moss, Director of the Center for Health Ethics and Law at West Virginia University Health Sciences Center, and Dr. Dale Lupu, Professorial Lecturer in Health Policy, School of Public Health at Georgetown, Washington University. I'll now turn it over to our presenters.
Thank you, Desiree. So I am a nephrologist, and I'm also a board-certified palliative medicine physician. And I like to tell my colleagues that just like we have transplant nephrologists, I think we're going to have more and more palliative care nephrologists. At last count, I think I counted about 50 of them. And Dale, you want to say something more about your background?
Hi, I'm a public health researcher and have been active in the palliative care field for 35 years. And with Woody, I'm working on building some bridging between palliative care and nephrology.
And we're starting off with this topic because this is the one, or one of the ones that when I talk to nephrologists, they say that they would like to be able to build their communication skills for talking about non-dialytic care or for end-of-life treatment. So that's what we'll be discussing today, and hopefully we'll be giving you some helpful tools and an approach to having these conversations comfortably with your patients and their families. Let me just, there we go. Just a disclosure, I'll call Dr. Lupo Dale. Dale and I are funded as co-principal investigators on the Pathways Project, and we'll be presenting some of the results to you. It's really an evidence-based innovation to improve supportive care delivery for patients with kidney disease, and it was funded by the Gordon and Betty Moore Foundation, and it's been administered through George Washington University School of Nursing. Our objectives are really to describe the successful implementation of advanced care planning and other supportive care best practices in this Pathways project that's now just winding down. We'll be role-playing the Ask, Tell, Ask approach and how you can use it in your conversations with patients and families. We'll discuss outcomes with the use of the surprise question. It's previously been validated in dialysis patients, but this time it was validated in a different set of dialysis centers, and identify ways to document patients' end-of-life care wishes that they will be known and respected. And at the end, I will talk about ways to bill for advanced care planning because you can improve your income for your time spent by billing for advanced care planning. I think it's important to start with understanding there are three terms that are thrown around a lot: goals of care conversations, advanced care planning, and shared decision-making. And as this diagram shows, really goals of care conversations includes both advanced care planning and shared decision-making. It's really whenever you talk to patients or patients and their families about what's most important to them, what types of treatments they would and wouldn't want. Advanced care planning is specifically when the patient has decision-making capacity and really stating their preferences for treatments they would want at a time in the future when they lost their decision-making capacity. Whereas really shared decision-making can occur with a patient with capacity or with their family member if they lack capacity. And it's about current treatment decisions. So many of you probably are used to having discussions with family members of very sick patients in the intensive care unit who have acute kidney injury about whether or not to do dialysis. And so you might be doing a shared decision-making conversation with a family member about whether or not to start dialysis. So here's our first polling question, just to get an idea of the experience of the people we're speaking to. How often do you engage in advanced care planning with your patients? Never, rarely, sometimes, regularly. And then if you just click the one that matches your practice and hit submit, then we'll see the polling data. So we'll give you 10 or 15 seconds or something like that for you to click.
Imagine the Jeopardy theme in the background.
Right. Steve, will you be able to bring this up for us then? Okay, so regularly. All right, so this audience is not shy. This is great. So 44% said regularly, 1 to 2 patients per month. So that means every couple of weeks, sometimes, and never. All right, so this is we're dealing to an advanced audience. All right, that's helpful to know that. So the next question is, what's the biggest barrier to integrating advanced care planning into your practice? And if you can bring up the poll again, it takes too much time. Looks like that's repeated twice there. Patients don't want to talk is what the second one was meant to be. I don't feel skillful or competent with it, or it's not part of my role. Okay, so if you could, and the second one is patients don't want to talk. We'll see what people say. Okay, so the one takes too much time. All right, so the good news is this ask, tell, ask conversation, I've actually, it's taken me 15 minutes sometimes to do it. It's fairly straightforward. You can, as long as you make it 16 minutes, you can bill Medicare code 99497, so you can actually then recoup your time. So that's helpful. Okay.
And then Woody, that second one of patients don't want to do it was actually the highest. So we'll want to respond to that as well.
The patients don't want to talk about it, you mean?
Mm-hmm. Mm-hmm.
Okay, all right.
Yeah.
And it's also, of course, to some extent, how do you present it? Okay, I'm sorry, I'm having trouble advancing. Okay, Dale, you want to, let's see.
So we wanted to start by, we hope, encouraging you by telling you a little bit about the Pathways Project, which did successfully implement supportive care, including a big emphasis on advanced care planning in 10 dialysis centers. Let's go to the next stage, next slide.
Okay.
So if you want to read through this little case of the frail 82-year-old widow, she's been on dialysis for 5 years. She's getting weaker and more confused. She lives with her daughter, and her daughter's very faithful about taking her to dialysis. She's been hospitalized 3 times in the last 6 months. And she tells the technician one day, I just don't know how much longer I can do this. And now if you read through the steps, I'm not going to read through all of them, but I would expect that this is familiar, that things escalate, which is why we're going up. She goes back to the hospital. It's a surprise to the daughter. She dies in the hospital, and the daughter is just kind of shocked that this all happened, and it just felt like a ton of bricks. So this is what we would call a predictable emergency. And in Pathways, what we were trying to do is give the dialysis centers the skills to anticipate, plan for, and avoid the emergency part of this by doing planning. Let's go to the next slide. So we have another poll, and we want to ask you, what did you think the daughter's estimate of her mother's prognosis is? So 3 to 5 years, 1 to 2 years, 6 to 12 months, less than 6 months. What do you think she's thinking?
All right.
Yes.
This is an experienced group. They've been around the block before. Okay, notice nobody has what's probably more likely to be the case. All right, well, that's very good. All right, so let's move on. And I'm sorry, So let's talk about prognostic awareness of dialysis patients, and it certainly could extend to what their families think as well. And this was a study that was done printed in JAMA Internal Medicine in 2019, and they asked over 900 dialysis patients, how much longer do you think you have to live? And what you can see is the really dark, I think you can see my cursor. Can you see my cursor? This prognostic expectations. So excluding the 40% who didn't know, the other 60%, most of them thought they had more than 10 years to live. And these were dialysis patients who were on average over 60 years of age. So these were already, sort of average age dialysis patients, and most of them that thought they had more than 10 years to live. And then what this next row shows is that actually 60% of dialysis patients die in less than 5 years. And this is USRDS data. And then of course, this bottom row is transplant patients do much better. So that, the vast majority of transplant patients will live more than 10 years. But the point is that, patients way overestimate their survival on dialysis. And part of this Ask Tell Ask conversation is really getting to what the understanding is in the first ask, and then telling something about the prognosis in the tell portion. Back to you, Dale.
So in Pathways, we were working with 10 dialysis centers and 3 CKD clinics that were associated with them. We have an evidence-based, what we call change package, which is best practices for the whole range of supportive care. But we concentrated in this year and a half that we were working together in the Learning Collaborative, we concentrated on 3 best practices. So one was identifying those patients that we call seriously ill. So those with the surprise question that you wouldn't be surprised if they died in the next 6 to 12 months. Probably the patient case, you wouldn't be surprised because her condition is deteriorating. And then conducting these goals of care conversations. So again, as Woody said, we concentrated a lot on advanced care planning, but one of the things that really evolved during the project was a less rigid, protocolized advanced care planning, but really conversations, chair side, 5-10 minutes of conversations that would build on each other. And then once you know what someone wants, can you offer different options? And again, we concentrated on palliative dialysis, which only one center was doing when we started with them. And then a process of systematic withdrawal for those patients who said, like our case, I just don't know how long I can keep going. And that involves hospice or palliative care coming in. Next slide, Woody. The next slide, this is the organizations that participated with us. So Rogerson, American Renal, Atlantic Dialysis, Dallas Nephrology Associates, and the VA in Washington, DC. So, I assume some of you are probably on the call, and thank you for participating. And here's the next slide is an overview of our main findings from our, we're still analyzing. So, the researcher in me says, it's not quite all tied down yet, but basically this is the big picture. First of all, we were able to help the centers implement into existing workflow. So we weren't adding staff, we weren't, this is just using the resources in dialysis centers, and the dialysis centers themselves came up with the ways that they could integrate into, for instance, their unstable care planning meeting or the existing quality improvement work that they were doing. The Woody's going to talk more about this, but just the big picture, nephrologists were surprised at how useful the surprise question was. And when we reported the data back about 6 months into the study that they actually were identifying people who were dying. This really lit a fire under staff to realize that this wasn't something that you could just keep putting off and keep putting off. Of course, it always takes time to help people get comfortable with new things they're doing, new processes. And we saw a trend that was interrupted by COVID-19 of more goals of care conversations and more patients as a result, we think, of that dying at home. And then, of course, COVID interrupted everything. 6 of our centers were in Manhattan and Queens. So as you can imagine, they were in part of the really initial first wave. And I'll show you from a staff survey. Staff reported at the end that they really felt a lot of improvement, especially on those 3 practices we worked with them on the most. Woody, let's go to the next slide. So here's some baseline data. We interviewed patients at the beginning of the project. And those patients, most of them said 70% said it was very important for them to discuss what they would want if they became so ill they couldn't speak for themselves. So again, when you think about that, what you guys told us, that you're having trouble, that patients don't want to do it, there's some kind of mismatch, because they say that it's very important, but then you are experiencing that they don't want to do it. So that's a problem we want to work through. And of those who said it was very important, most of them, 69%, said they had not had such a discussion. So they say they want it and they say they're not having it. Let's go to the next slide. Next slide is our kind of quality improvement data. We were tracking what of the 10 sites had they had any goals of care conversations. And you can see that nice rising trend through January of 2020, and then our little COVID drop off, because when COVID hit, all people could do was infection control, and yeah. So we don't really know what would have happened without COVID. We think that we would have continued that upward trend. We had worked with sites to say that they should prioritize. One of the things sites, dialysis centers, say is we can't do everybody. So how do you prioritize? So the prioritization we made was, first, you're identifying who's seriously ill with a surprise question, and then also you're saying who's just come back from the hospital. That's a time when you can introduce this concept in a really natural way. You just came back from the hospital. What was it like? What did you learn about your illness? What are you thinking? Has anything changed in how you're thinking about your health? And again, we saw the rising trend, but then COVID, of course, interrupted that. Next, we looked at documentation in the chart, and on the left is what we are calling our primary outcome. So we looked for several different indicators. Was there a goal of care conversation? Was there an advance directive? Was there a healthcare agent documented? So there are a number of different things. Our primary outcome was, or did any of these happen? Goals of care, or an advance directive, or a DNR pulse. And you can see it went from baseline, about 53% of any one of those in the chart, to follow up at about 80%. We also looked at what we call complete advanced care planning, which is you would want to have a healthcare agent and a conversation documented and the paperwork. So either an advance directive or a DNR, or it could be which can be a pulse or a MOLST. And that also went up from 27% to 43%, both being statistically significant. So sites were successful in raising the bar, although we would still like to see it get even higher. Let's go to the next slide. I guess we're not showing the, okay. We also had some staff survey results in which we surveyed the staff before and after, and staff felt that their centers, they weren't doing it themselves, but that their centers had really improved on all of these practices around identifying seriously ill patients, assessing their needs, documenting conversations. So the goal then, after you do these practices, and you can read the boxes, is that you would be proactively identifying these seriously ill patients, and you would know what they want. So in this case, we're saying the patient says, I don't want to go back to the hospital, I want to be at home. So another patient might say something different. This is not about that we don't want anybody to go to the hospital, but this patient says, I want to die at home, or I want to be at home. People don't say I want to die at home, they just say I want to be at home. And so as the team sees the decline, they are then proactively guiding patient and daughter and putting plans in place so that it's a better end of life that is concordant with what the patient wants. And in addition, the daughter is going to have a easier time of bereavement. And we didn't measure this, but I would contend your staff feels better about it as well. They begin to feel that they're really helping people have a calm, satisfying closure to their life rather than kind of a traumatic ICU experience. And there's some good research that ICU creates PTSD of quite long standing for family members who go through that experience with the patient. Lydia, I think it goes to you now.
Right. And I'm just going to say a little bit more. So when you think of that frail 82-year-old that Dale presented a few slides back, this slide also is recounting the fact that sometimes, the daughter is still thinking mom has 3 to 5 years to live, but the patient is saying, I don't know how much more of this I can do. And the patient is saying she doesn't really want to go back to the hospital. So if you're familiar with the physician orders for life-sustaining treatment or the variation of it, the most form, whatever your state uses, you would fill out that the patient would want limited additional interventions and not full interventions, or even that she might want comfort measures as opposed to limited additional interventions. But the whole point is when you can talk to the patient, find out what's most important to the patient, the family usually is willing to go along with it. And so this would lead to an outcome where the patient would be able to die at home with hospice support. And then there would be the hospice bereavement support to the daughter as well. So before we go any further, and we're about to get into the Ask, Tell, Ask conversation, and Dal and I are going to role model it for you, just to make you aware of the fact that, and in fact, I think Desiree sent you even a copy of the Ask, Tell, Ask card, but you can go to this website at the bottom, the http://gwu.edu, Ask, Tell, Ask, and you or your colleagues, your social worker, anybody you want can go and download that and use that. I know our teams often, we gave them 3x5 laminated cards and they kept them in their pockets, and they found it very helpful to them as they were first learning how to do it. And then we have an entire change package with 14 evidence-based best practice recommendations for things like pain and symptom management, active medical management without dialysis, which will be our topic next week. Pain and symptom management will be our topic in 2 weeks. But you can see all of the practice recommendations and the evidence to support it and the tools to implement it at this website. So here's the Ask, Tell, Ask card. This is what was emailed to you. And notice, and we'll come back and talk about it, even in the bottom right-hand corner is information about how to bill for it and how much time and how to document. We'll go through that in a little bit. But let's just demonstrate the Ask, Tell, Ask. Imagine that that Dale and I are I'm the nephrologist and Dale is the daughter, okay? And the patient has been admitted to the hospital, and the daughter is upset that her mom is sick and back in the hospital, and I'm making rounds, and I'm coming to see the patient, and I see that the daughter is sitting in the room with the patient. The patient is confused and really unable to participate in the conversation. And so I'm going to say, I'll call the patient Dal just to make things easier. Good afternoon, Dal. Good to see you. Sorry to see you under these circumstances.
Hello, Dr. Moss. Yeah, thank you.
So I don't know how much you know already. What's your understanding of where we are right now with your mom?
Well, today she looks kind of bad, but she's been here before and she always bounces back. And yeah, I'm just hoping in another day or two she'll kind of get back to herself, and we'll get back to what we were doing before.
I understand that she fell at home. Is that right?
Yeah, she did, right going out the front door.
Okay. And from what I gather, this has been happening slightly more often recently. Is that right?
Yeah, they haven't been bad falls until this one, but yeah, just she seems like she'll lose her balance, and then she doesn't want, she's scared, so she doesn't want to move around as much, and we're trying to encourage her to keep moving because that's important.
So it sounds like she's getting weaker. Do you think she's getting weaker?
I think she just needs to try harder.
I see. Okay. How serious? How serious do you think your mom's condition is now, perhaps even compared to a year ago?
Well, like I said, she kind of bounces up and down, but she always is really happy to be home and see her grandkids again. And I'm just hoping she'll bounce back. She's bounced back before.
Yeah. Now, the other thing that I'm worried about is she does seem to be more confused. I mean, typically she might have been able to participate in this conversation with us a year ago, but really in the last couple of months when I've seen her on dialysis, she's not always awake. And even when she is awake, she's not often clear about what's going on. Sometimes she starts pulling at her dialysis needles and we need to sort of remind her, no, you can't do that. So I'm concerned.
Yeah. I think, the nurses have been telling me that that's happening more in the center. She does come home awfully tired. And but I just feel like if she could just like get herself moving again and eat well, that she would bounce back.
Mm-hmm, mm-hmm. If your mom was perfectly clear mentally and she could sort of hear our conversation, a little bit more confused, somewhat weaker, more falls, what do you think she would tell us she would want at this point?
Well, I know what she wants. She wants to see her grandkids. That's what she wants.
I see.
She wants to be home and see them. That is the joy of her life.
Okay. Has she ever talked to you about types of medical treatment that she would want to avoid?
Well, the main thing she has said is she really hates going to the hospital. And the other thing she said was that her sister was on a breathing machine, and she said, I don't ever want to do that.
Mm-hmm, mm-hmm. Has she documented that maybe with her primary care physician? Has she filled out one of those?
Not that I know of.
Okay. So if she wouldn't want to be on a breathing machine, then that usually means that we wouldn't be doing CPR, because if we did CPR and
what's CPR?
I'm sorry, that's where the heart stops and we shock the heart and we press on the chest to try and bring the heart back. Have you not heard about CPR?
I mean, I've certainly seen it on TV,
Okay. Well, we should have a further discussion about that. And I might, if it's all right, I might even get our palliative care consultant physician to stop by and provide you with a little bit more information about that. But thank you. I'm glad that you.
Palliative care means she's dying?
So palliative care means just what you and I have been discussing, that she is going downhill, that she is weaker, that she's more confused. And yes, overall, her condition has gotten worse. From my standpoint, her condition has gotten significantly worse in the last 6 months or so. If you recall, she's been in the hospital multiple times in the last 6 months, much more, than in the previous year. So that really,
you're saying you don't think she's going to bounce back.
Well, I'm worried about that. I wish she would. Obviously, I wish she would, but I'm worried that she might not. And you're telling me some important things. You're telling me that she wouldn't want to be on a breathing machine. And if she wouldn't want to be on a breathing machine, then we really need to address this whole issue of cardiopulmonary resuscitation, or CPR. And we don't need to make the decision this moment. Okay. It's, it's not immediately urgent, but I think we should, while your mom is in the hospital this time, have further discussion about this, and I'll get someone in to help explain some things to you, and then we can talk about it again, okay?
Yeah, I would like to talk about it. And I think, I do think the thing she said is she doesn't want it. She just hates being in the hospital.
Yeah, yeah. And I don't know if you know, but last week in the dialysis center, she actually said to one of our technicians, I don't know how much longer I can do this. Did she tell you that?
No, I think with me, she's pretty brave because she knows I don't want to lose her.
Okay, okay. Now, if we would have had a more complete discussion, let's just step out of our role
Yes,
for a minute.
yes.
Say that I would have had the discussion, would have had a little more time, and I would have actually identified that really the daughter was sure her mom would not want to be on a breathing machine. And I explained that to have CPR in the hospital, patients end up on a breathing machine, and the daughter reluctantly but agreed that her mom wouldn't want to have CPR. That if we agreed that that her mom would receive all the current treatment but not be going to the intensive care unit, not being put on a breathing machine, not having CPR, then what I would do is, I might swing back. So let's get back into our role for a minute, Dale. So Dale, your sister wasn't able to be here for this conversation that we've just had. What will you tell her about what we discussed?
Well, I think the big thing is you said she's going downhill, and our hopes that she's going to bounce back may not. I mean, you said you hope so too, but you don't think so. So I think that's really the big thing.
Okay. And what questions? Do you have any questions about what we discussed?
I think the main thing, well, you talked about some forms, so like when we do those, but I also think it's really how can we keep her at home? That's what she says. I don't want to go to the hospital.
Okay. Okay. So we can discuss that further. There is something called hospice. I think we were talking about that earlier.
Yeah. That's for people who are
Sometimes,
dying.
well, it's for people where we feel they have 6 months or less to live if the disease takes its normal course. And unfortunately, with the rate at which your mom's been going downhill, I mean, we have to look at her diagnoses and see if she has a non-kidney related diagnosis, and then see if we can find a hospice who would be willing to accept her. She's had a stroke in the past, and I wonder with some of these weak spells and confusion, whether or not we might be able to get her on hospice because of her neurologic condition. And if so, then we could refer her to hospice, and hospice could work with you then to make sure that your mom is able to stay at home at the end of life and not go back to the hospital. And that would then be honoring her wish.
Yeah. Yeah. Well, that's a lot for me to think about because
Okay. All right. Well, we will end our role play and we'll move along, but hopefully this gives you a flavor. So just to sort of review what we do, we start by assessing the patient's understanding of what, in this case, the daughter's concerns were about her mother's condition, and then asking some of these questions that we've just asked. And if the patient had capacity, we would have asked her what was most important in receiving treatment. And she might have told us that she wants to be comfortable, wants to be home as much as possible. And what did she hope for? She might have hoped for more time with her grandchildren and what she would want to avoid. And she might have said a breathing machine because my sister was miserable when she had that. We would want to make sure who she would want. If she's not done an advance directive and appointed a healthcare proxy, we would want to make sure that it would be Dale or Dale's sister, or she's a widow, so it would, so her husband's out of the picture, but who it is that you would want to be the decision maker. And then we could have even turned to Dale and say, what are you thinking about your role as the decision maker? Do you feel prepared to make decisions for your mom? Do you know what your mom would want? And so those would be part of the discussion. The tell is giving information related to worries that the patient or the family member might have. And notice, I think Dale's reaction was fairly common, in somewhat denial. Mom clearly had been going downhill. She knew she was going downhill, but Dale was telling herself, oh, well, we're hoping she's going to bounce back. And, she's been to the hospital before and she made it home and there weren't issues. So you have to deal with those things. And of course, this it also could be in the context of if the patient got COVID, and that talking a little bit in the tell portion of the discussion, if the patient were in the hospital and did have COVID, what that might mean. And I think we're all aware of the fact that the much higher mortality rate for dialysis patients with COVID than for other patients with COVID. And then the final ask that we demonstrated is, what questions do you have now, so that I can make sure I did a good job explaining. Tell me in your own words what you understood from our conversation, and what are you going to tell your family about what we discussed. So those are that's sort of the ask, tell, ask, and you have a card where you can see how to do that. So once you've had the discussion, it's important that you document it so that other people in the healthcare system know. And you could, if the patient had not done an advance directive and wanted to name her daughter Dale as their decision maker, certainly you would want to get the social worker to assist in advance directive completion. Certainly a physician orders for life-sustaining treatment, or a medical orders for life-sustaining treatment called POLST or MOLST, depending upon your state, as well as notes in the medical record you would want to complete to document, so that the healthcare system would know how to respect the patient's wishes. And then just to be aware that there are stages in advanced care planning, and healthy patients, and I'm hoping that most of the people listening would fall under that category of being healthy. Hopefully you've done an advance directive, medical power of attorney, maybe a living will, depending upon your preferences. And then certainly it would have been appropriate for our patient to have done advanced directives, as this line shows her disease trajectory and the hospitalizations and sort of the overall downhill course. And then certainly we're to the point where we wouldn't be surprised if she died in the next 12 months, really 6 months. And so it's important that a POLST form medical orders be completed that would give all those taking care of the patient orders on what to do if the patient were to collapse and lack decision-making capacity. This is just a picture of what the West Virginia post-form physician orders for scope of treatment looks like, but it has similar names in other states, and it has a section on CPR and a section on what level of medical intervention is desired, comfort measures, limited additional interventions, which means going back to the hospital, and full interventions, which would include the intensive care unit, and also wishes about IV fluids and feeding tubes. So the surprise question, we said we would talk about that. It's turned out to be very valuable in the hands of nephrologists and nephrology nurse practitioners. And we think even in the hands of experienced social workers, asking yourself, would I be surprised if this patient died in the next 6 months or died in the next year? And if you say, no, I would not be surprised, that really should trigger things like we did now. It should trigger an ask, tell, ask conversation to find out what's most important to the patient. And in the one study that I did with Mike Germain and Luke Cohen at Bay State Medical Center, we used 6 months for the surprise question, and then we're able to validate its usefulness as part of a whole paradigm for identifying patients who are at increased risk for mortality in the next 6 months. So in the study that we did in going way back to 2008, if we said, no, I wouldn't be surprised, those patients were older, they had higher comorbidity scores, lower performance status scores, lower albumin scores, and their mortality was significantly higher, and their odds of dying within a year, the odds ratio was 3.5 and was statistically significant. And then we validated that in the study we did with Bay State Medical Center. And we've been using the surprise question then in this, we used it in the Pathways project that we're presenting to you right now. And what we found is when the nephrologist identified patients as seriously ill by saying, no, I wouldn't be surprised if they died in the next 6 months, those patients for whom they said, no, I would not be surprised, had a 9-month mortality of 27%. And those that they said, yes, they would be surprised, had a 9-month mortality of only 3%, with a risk ratio of 8.5 to 1, which was highly statistically significant. And I think Dale reported to you that our nephrologists were pleasantly surprised to see how effective this could be in identifying patients for whom they should be making a point of having goals of care conversations. And what our dialysis teams really found out to be most useful was when they had one of those seriously ill patients and they were recently hospitalized, to make sure that they had a goals of care conversation with them within 30 days of hospital discharge. Dale, and if you want to say something more about that, you're on mute.
Yeah, so just to say, Woody, we had a good question in the chat, which when you go to the next slide on the process of advanced care planning, you could address. It seems this is the question, it seems there's often a disconnect in what the patient's voice versus their family in terms of long-term goals of care, to the point where it almost doesn't seem worth it to have the discussion with patient alone. So maybe when you go to the next slide, you want to talk about that a little?
Sure. Yeah. So, so what you really want to do is you need to have the discussion first with the patient if the patient has decision-making capacity. And maybe even you do that briefly on dialysis rounds and you learn that. But then you do need to sit down with the patient and the family and make sure that they are communicating with each other, because often they're not. For example, the patient in our case that we presented really wasn't sure how much longer she could keep on going. It was really getting very difficult for her, but her daughter really was optimistic and was unaware of that. And so sometimes you need to facilitate a conversation in which they're both in the room at the same time, talking to each other. And this is also where you should feel free to get a palliative care consultation to assist you in having these types of discussions. But really, there are prognostic markers that you can do as well. The hemodialysis prognostic index that would include not only the age and the answer to the surprise question, but also whether or not they have dementia. The patient was getting more confused recently, and whether or not they have peripheral vascular disease. So you could estimate their prognosis. You could talk to the family about what you see going on with the patient, and you could try and really have a discussion. And it was interesting that the daughter knew that her mother really did not want to go back to the hospital and was willing to respect that wish. And so really you could pick up that conversation at that point and talk about, all right, so what are the contingencies then? What would we be doing if your mom did have a really bad fall, or if she really did get confused, or if she really became very difficult to transport her to dialysis except by ambulance, let's say, and start discussing some of those. What more did you want to say about that, Dale?
I think we saw that when you can concentrate on everybody agreeing that the patient, this is the patient's, whatever it is that they want. If there's agreement, you're not asking people, are you going to pull the plug right now, right? But if everybody agrees that mom, grandma doesn't want to go back to the hospital, or agrees that her main goal is being home, whatever the goal is, that you can get agreement around that. And I think social workers are your ally in helping you have those conversations in the times where family and patients seem not on the same page.
Right. And our colleague, Glenda Harbert, who's a dialysis nurse and former ESRD network executive director, commented that really sometimes you can do this by telehealth. And Glenda is quite right. Many times I've had the patient who maybe is at work, the patient's daughter rather, who's at work and couldn't make it in. I have the patient in the office, or the patient in the hospital bed, and I have the daughter on the phone, or maybe even we're doing it, by FaceTime. And we're talking really that way. We can sort of communicate, bring everybody up on the patient's current status, and then talk about the things the patient would and wouldn't want. And that's really part of this goals of care conversation, this ask, tell, ask conversation. And, if the patient's really able to express her wishes, and the daughter is willing, or the healthcare surrogate, who's ever serving as the surrogate decision maker, wants to respect mom's wishes, as they usually do, then you can begin to plan, all right, what does that mean? Do we need to do a post form? Do we need to put a do not resuscitate order in the hospital chart? What do we need to do? All right, so let's just talk a little bit about billing, because you can actually, over and above your E&M code, you can bill for the time that you spend having these conversations. And your nurse practitioner can do it. The face-to-face, and it has to be at a minimum 16 minutes. But what I found is that often I will have done an office visit, whether it's a 15-minute office visit or a 25-minute office visit, depending upon the urgency of the situation, and squeeze in. Yes, it gets me a little behind, but sometimes if it really needs to be done because the patient really is going downhill, or can be done in the hospital as well, where maybe the time might be a little bit more flexible. But the physician allowable is $86 for 16 minutes, which isn't too bad. The nurse practitioner allowable is $73. Now, if you end up spending at least 46 minutes, then you can actually bill in an additional $99498 with, again, another $75 on top of that. I realize it's not great reimbursement, but at least you can get some of your time back. And these are time-based codes. So if you spend 46 minutes in advanced care planning, you can bill for the 99497 and 99498 for your.
And we have a question in the chat.
Yes.
How do you manage this kind of conversation when in real life you are really so tight in time and have to see so many patients? Is there really a realistic solution without coming across apathetic and rushing the conversation?
Yes. So that's where you should feel free to get a palliative care consultant, whether a physician, nurse practitioner, whatever is available. If it's available to you, and be very explicit with them. What you see, this patient is going downhill. I'm very worried about their condition. I'm worried that this is just the beginning of the end. And in fact, the daughter told me the patient would not want to be intubated. So if you could come talk to them about goals of care, talk to them about what it would look like, talk to them potentially about hospice with her neurologic diseases, a terminal diagnosis. So those are things that you could do. But
the other thing is, in Pathways, what we saw in some sites, different sites had different ways of doing this, but in a number of sites, the nephrologist was really empowering either their nurse practitioner or their social worker, or the nurse practitioner and social worker together to do this. So it was the nephrologist was probably not billing for it, right? But was opening the conversation and doing what we call the warm handoff.
Yes. And so you're right. So in several of the dialysis centers that were part of our Pathways project, they set aside Tuesdays and Wednesdays. They set aside an hour to do an advanced care planning discussion with whichever patient was seriously ill, had recently returned from the hospital, and they thought there was some urgency to sort of figuring out exactly what the patient's goals of care were, what treatments they wanted, what they didn't want. So you would then prioritize. And honestly, in our Pathways project, it was mainly nurse practitioners and social workers together having these conversations, documenting them. Depending upon the state you're in, nurse practitioners can sign post forms, and you can really then have a plan in place so that you can respect your patient's wishes and provide them with the type of treatment they would want. So really, I think that's the type of care that all of us would like to provide to our patients. We'd like to know what's most important to them, and we'd like to be able to respect their wishes.
And I will say that both nurse practitioners and social workers came to feel, they didn't feel this way initially, they came to feel very good about these conversations. And they said it really helped them get to know patients better. The social worker said, now I feel like I'm really working, I'm doing what I'm supposed to be doing. This is what I'm trained to do. I'm not just arranging transportation. There was a lot of, once they got over the hump and once they figured out how to integrate it, including some of this more casual chair side, just, how are you feeling? What are you hoping for? What are you concerned about? Not necessarily a formal sit down, do the forms. They liked doing it.
Right. They did. And it's inpatient. These are inpatient or outpatient billing codes. One of the questions in the question was, is this only outpatient? These can be done. And really, you don't have to complete any forms. You can have discussions about, whether the patient wants dialysis or wants a medical management without dialysis. And that you can also bill for that under these codes. So, it doesn't have to be just DNR or intubation or not. All right, there's starting to be some questions. Let me just move on to the next slide. You can just finish our slides and then field some more questions. So these can be billed, here we go, on inpatients or outpatients. They can be done as standalone or concurrent with an office visit or hospital care. They can be billed along with modifiers if submitted on the same day as another service, such as the dialysis monthly capitation payment. So you want to get with your billers and coders and they'll look up the rules. But this is really fairly flexible and there's no limit. You can have a discussion and then a month later, if the patient's condition worsens, you can have another discussion and you can continue to bill for these conversations. All right, and then documentation, and you can get the slides. Just ask Desiree, or maybe Desiree, you're sending the slides out to everybody. This is what your note would look like. An advanced care planning discussion was held with the patient and the patient's wife, and in which the purpose of, in this case, the daughter, which the purpose of advanced care planning was explained, patient's values and goals of care were elicited, and the patient's choice of, let's say, her daughter to be her decision maker in the event of loss of capacity was discussed. The time of this advanced care planning with the completion of whatever advanced directives or medical orders does not include or overlap with the time spent on the E&M component. So this would allow you to bill your E&M component, and then the total time for the face-to-face counseling, it needs to be at least 16 minutes. If it's, and then if it's 46 minutes, you got into a long conversation, you can build 99497 and 99498, and you can build these as smart phrases into your medical record system, and then it really does facilitate things. So Dale, you want to do these last few slides?
Yeah, just to tell you that from the Coalition for Supportive Care of Kidney Patients, we've got lots of resources for you. We're in the process of publishing more results. We've been presenting at all these virtual conferences. One of the things I would point out to you is we have developed with the folks in Pathways, we developed an active medical management without dialysis pathway. It's a whole toolkit. It's like a plan for patients. It's a letter you would send to their PCP. It's a whole toolkit for how can you, again, actively plan when somebody says they don't want dialysis. Because the experience so many nephrologists have is someone says they don't want it, but they end up in the end in the ICU anyway. So how do you really set up that safety net? Next slide.
Yeah, before you go, let me just point out, if you're interested in this, there's a whole Oxford University Press textbook now, Palliative Care and Nephrology. Dale and I were two of the co-editors for that. So you might want to grab that, where you would be able to get much more information.
And then we have a number of links we've developed, especially during COVID. We talked about the idea of emotional PPE, not just infection control PPE. And of course, this is beginning to be part of the conversation now as we talk about grief and bereavement. So lots of resources on the website that we encourage you to.
Right, including several 15-minute goals of care conversations to show you what they might look like with outpatients as well.
So we're open for lots more questions. Someone's asking, documentation for ACP is separate from the E&M note. Yeah, you want it in a place where you can easily find it. The ideal is a tab for ACP. If your EMR doesn't have it, you should agree in your practice some way that you guys can find it, right?
Right, but you should have a smart phrase that you tack on if it's an office visit and then you've done one of these conversations. You do need to either bill it as in conjunction with either a hospital visit or an office practice visit, or if you're doing it just independently, which you can do also, then I agree with Dale. Ideally, you should have some way to access these notes. They should be organized in your chart or electronic medical record in some way. Are you going to look at the questions, Dale, and ask them?
I think Desiree's, we have some questions. Desiree, are you going to ask us?
Hi. Yes, did you want to tackle the
Okay, so are these only
chat that you
outpatient
saw?
codes? No, they're, so, yeah, I was doing the chat.
Okay,
But-
so one of the questions at the top, I'm not sure what it refers to, but they were talking about outpatient codes. So it must have come in when you were talking about that. It said, are these only outpatient codes?
Right.
But do you know what they might be referring to?
Right. I think the 99497 and 99498. And so they are outpatient and inpatient codes. You can actually even have the discussion in the dialysis unit, but you would then need to get your bill encoder to add a modifier to it. So you can even do it in the dialysis center as well.
And then there's a question, I'll go ahead, Desiree. Was there pushback from nephrologists and dialysis units fearful that approaching patients regarding ACP would lead to patients ending dialysis and reduced billing or fee-for-service payment for treatments? Wait, I know you'll talk about it, but I want to jump in. We didn't get pushback on that, although people imagine that nephrologists worry about it. Where we got the pushback was on palliative dialysis, where people were very afraid it was going to impact their quality scores if they weren't keeping people at the expected regimen. And what we said was, we're working at a policy level to try to change that. But right now, if you think about it, if you have one patient on palliative dialysis, which is, you're not going to have a lot, is that really going to change your quality score? And so what would you like to say about that?
Yeah, and we're working with CMS. We're working, actually the Renal Physicians Association, we're working with their Quality, Safety, and Accountability Committee. We're actively discussing this and planning to go back and talk to CMS about trying to get these patients excluded from the other quality measures, so that it wouldn't penalize a dialysis center to have one or two patients who are at the end of life who are on palliative dialysis. The palliative dialysis, I think many of you know what that is. It might not be 3 times a week, it might be 2 times a week, might be 1 time a week, might be for 2.5 hours instead of 4 hours. It's really sort of tailored to what's most important to the patient.
We have a question. When do you discuss discontinuation of dialysis?
So I think, if you're very concerned, I mean, if the patient's hypotensive, every treatment is sort of a disaster, you might want to talk about whether or not it's technically feasible. But the other thing is, if the patient's just frequently getting readmitted and having more and more complications, that would be another time to sort of bring it up. When they're seriously ill and not faring well on dialysis, that's a reasonable time to consider discussing, with the family, what's your understanding of where we are now with your mom's illness? How serious is she? If the patient lacks capacity the way our patient did, what would she tell us if she had capacity now about what would be most important to her? Would she want to continue dialysis at this point? So, you would need to sort of have those conversations and try and figure out values and wishes.
We've got a question. Is there a program for active practicing nephrologists, not active fellows, perhaps online curriculum? So there is great curriculum for the fellows. I don't see any reason an active practicing person couldn't do the online curriculum that Jane Schell and folks have done. I would also recommend, maybe, Woody, can we put the chat, can we chat that link in? Vital Talk, I would also recommend. So Nephro Talk is what's been developed for fellows. Vital Talk has a great website. It's broader than dialysis, broader than nephrology, but they have great tools and short videos. That's a good communication.
Right. And the RPA has been really good for 20 years in addressing this topic as nephrologists express an interest. And that's the reason why we're doing this webinar today and the one next week and the one the week after. And if there is an interest, then, let Desiree know, comment on the evaluation that you would like more of this. And, at the annual meetings and the various webinars that RPA does, we can continue to make sure that content is provided.
I think we'll have time. I saw one more question come through. Why don't we take this last question here, and then we'll wrap it up for today. Dr. Lupu, do you see that question? Did you want to?
Yeah, is there an age, this is for you, Woody, is there an age limit that you use when discussing with family especially when asked if patient will do well on dialysis before starting hemodialysis.
So, England was sadly criticized for their age limit, which was 55 back in the 80s. There's no age limit because we all know 90-year-olds who are more fit than 60-year-olds. But a lot of the research that's been done is when patients are over the age of 75, especially if they have multiple comorbidities, then you do start to worry about how well they might do on dialysis. And there is, there are some prognostic scoring systems, and there have been articles written about how to sort of have these discussions. And if there's an interest, Desiree, maybe RPA would be willing to have, this is a great question, have a whole session on talking about this and talking about offering, not offering dialysis and what the options would be. We'll cover this to some extent next week, and we can make sure that we deal with it maybe a little bit more intentionally.
Yeah, and trials.
Great. Well, this has been an awesome session, and I want to thank everybody for participating. Thank you to Dr. Moss, Dr. Lupu, and the resources that they did mention. I will get with them, and we can send that out in a separate email. I think there was Nephro Talk was one, and
Vital Talk,
the other one that you mentioned.
Yeah.
But we'll make sure that we get that to you guys. So thank you all for attending. Just as a reminder, this is only the first session of the series. Our second session will be on June 16th, same time, implementing medical management without dialysis for seriously ill older CKD patients. And I will be sending out the link for that that Monday prior to the webinar. So you will receive that. The recording I will make available on the RPA website. So I will let you know when we have that up there as well. So again, thank you to everyone for participating, and we hope you have a great evening. So thank you,
everyone.
Thank you. Bye-bye.
Bye-bye, everyone.
Bye. Bye-bye.